really discussing the situation of that patient, and the patient can discuss with a different specialist instead of coming from one to the other, to the third, to the fourth doctor, and getting 4 different opinions. That will confuse patients with HHT. So if there are burning questions and there are different organs involved, we try to invite the patient to these boards. Then we have what we heard from Dr. Bohlen as well. So we have a coordinator, and the coordinator coordinates patients in general with congenital vascular malformations. We call it the Congenital Vascular Malformation Service. We run that since 2008, and that includes HHT. Since 2 years, we decided to separate that a little bit, because patients with HHT often say, no, they don't have an HHT service, because it's covered behind this Congenital Vascular Malformation Service. So we relabeled that, including a special outpatient service and a service for patients with Morbus Osler HHT. So patients can come from Inselspital internally. So if the patient was referred to, say, the gastroenterologist or to hematology, and there is a suspicion for HHT, they refer the patients to this service. Or the referring physicians know, okay, I can refer my patient with HHT, or where I suspect or where I have question, to this service. And here we have, and this is something we heard before, we have a pretty close patient-doctor relationship. So if these patients, whether they have vascular malformation or Marfan's disease or HHT, if you refer a patient like that in a hospital, like a university hospital, I call it they are lost in space. They need a doctor who knows about the disease, they can have the question to, and who knows how are the standardized procedures. Not just doing everything, but reflecting. For example, what I said before with moms and dads about children. Do I have to do everything? Do I have to be afraid? So what's the right procedure for my child? So there is one doctor in that service, and if there are more questions to other specialists, this doctor goes with the patient to the interdisciplinary board. And I think this is the bottom message behind rare diseases and servicing these patients. And this doctor should then think about, okay, what is needed? Means this doctor needs to have all the knowledge we had heard about from Dr. Bohlen before. That was a great presentation, but the doctors to have and keep that all in their brains to make the right decision for the individual patient. Once more, I want to underline, so the most problematic situation in HHT that needs screening, always, lifelong, and that needs treatment of closing the AVMs is pulmonary AVM. About 30% of the HHT patients do have pulmonary AVM, and that's the problem that creates brain infarction, stroke, and abscess in the brain, and that's the disaster. And that gives the highest risk for pregnancy in HHT if that goes into a pregnancy being undetected. So the regular scheme is very simple for the patient. Today we do an echocardiography with bubbles so that we can see, is there a shortcut between the artery and the vein that directly comes from the right to the left ventricle, and we can easily detect that without X-ray. If that is positive, then the patient goes to X-ray to verify the size and the location of an AVM, and that always have to be occluded. What about children? It's a different situation. They still grow. So do we want to go and get all these patients into an echo, an MRT, or CT? The children will not go with it. So you need sedation. So that would make it too much complicated. And as I said, if the general examination and the O2 saturation and an X-ray of the lung is okay, or maybe in the family we know it's not the genetic trait that goes with pulmonary AVM, it might be wise to wait and control the child over time, and maybe to inform the patient that in case of, say, the need for endoscopy, the child might get an endocarditis prophylaxis. That's important. Inform the patient that endocarditis prophylaxis is important, lifelong, even if the pulmonary AVM was closed by a doctor this year. Maybe in 5 years, the smaller sized AVM is not seen at that time, enlarged over time, and the patient is at risk again. So if a patient is in the trait of pulmonary AVM from the genetic background, the patient needs lifelong follow-up by bubble echo. If that's negative, you can go for the next 5 or 10 years, but you should keep the patient probably on endocarditis prophylaxis, because you never know how fast does a small AVM close. So this is in a center with standardized procedures, what's recommended today by the European Reference Network on Rare Vascular Diseases. This is the organization we cooperate with, that's the CERN. And are the outcome measures for HHT being recommended today. So it should be screened for pulmonary AVMs, always screen for pulmonary AVMs. And the threshold should be that 90% of patients with HHT should have done screening. But I still see some patients not being screened, becoming pregnant in a female situation without being screened. That should not happen anymore. Or patient coming into the hospital with a family history of HHT, maybe even known HHT, not being screened for pulmonary AVM and seen for the first time with a stroke. That should be in the past. So this is something the European Reference Network strongly recommends. Patients should have a nosebleed advice in a written form. So this is, we have a standard. We got that in the 3 languages of this country, and it's based on the European reference networks. They should have the iron measured and the anemia tested at each consultation. It always can be either from nose bleeding or from GI bleeding going under recognized. This is something, if this is okay, we don't have to go and look into endoscopic screening in these patients anymore. If there's no anemia, if there's no iron deficiency, the patient does not have to undergo screening endoscopy anymore. Pulmonary AVMs in these patients, they need or receive a written advice on antibiotic prophylaxis prior to dental or surgical or endoscopic procedures. This is important. And I keep all my patients, even if a pulmonary AVM is closed by endoscopy, by interventional means, and the bubble is negative. So the next screening for that is maybe in 5 to 10 years. But I keep them on endocarditis prophylaxis because you never know when this happens again. Pregnant women with pulmonary AVM receive a written advice on pulmonary AVM in pregnancy. So if an HHT female wants to become pregnant, they have to undergo bubble echo screening, and in case of a positive echo, a CT, and treatment of pulmonary AVM before pregnancy. We have the same international networks we work with. So it's the German HHT Selbsthilfegruppe. We are collaborating with the European Reference Network, with the HHT working group, and I have a good connection to the American Cure HHT organization. We are collaborating, updating our guidelines from time to time. thank you very much for your attendance. And are there questions to my address? So there is one question directly to my address from Matteo. I am planning a gastroscopy and colonoscopy. Would you suggest, although a small intestine endoscopy via capsule endoscopy? No. So if you are not severely anemic, I would not suggest. If you don't have a clinically obvious anemia, no. Unless you have recurrent bleeding that needs transfusions and it's not explained by epistaxis, then I would do, because then it might be even an indication for operation to resect that part of the small intestine. Usually it's not recommended. So there's a question. If the child has no HHT, does that mean that the HHT stops for this family branch? I guess it's related. If this child is an adult and wants to get children, that these children will not get the HHT. That is correct. It depends a little bit on the definition of HHT. So the problem here is that it might be that manifestation, so the clinical phenotype is not so obvious. And if this child later on wants to make sure that their children don't get the disease, they should undergo genetic testing.
I think that the question was, since in his son the symptoms began to appear earlier than his symptoms did, does that mean his son will be more seriously affected by the disease?
No, we actually don't know, and I think we have to follow the clinical course. The heterogeneity might be so different that we can't say the prognosis will be so and so. The patient anyway needs to be followed, whether these are children or adults. There is not so quite clear prediction for the clinical course.